Hi everyone, it's Cathy Minter and welcome back to this episode of our Sage Space podcast. And I'm really excited about today's conversation. We have here as our guest Tiffany Shubert, and Tiffany and I had the pleasure of meeting recently a couple months ago down in Orlando at the On Aging conference, and we've just had so many great conversations since then. And I invited her today to talk about a lot of different topics, but just to introduce Tiffany. She really is an expert in the space. She has her PhD in human movement science. We'll find out a little bit today what that actually means. And she's also a licensed physical therapist and really has done so much work in the field of fall prevention and fall programs. And I'll let her tell us that in her own words. But anyway, great to have you here today, Tiffany.
Thank you so much, Cathy. I'm really excited to be here.
Yeah, no, this is great. I know we can talk for a long time when we get on our calls, so we'll try to keep it kind of to the topic today. But before we kind of jump into some of the other topics, can you tell our listeners just a little bit about you and your journey and kind of what you're working on today?
Yeah, no, I would love to. So I got into this space of working with older adults way back in 2002. And at that point in time in my career, I had been a physical therapist since 1997. I did all my physical therapy training in California. And then I moved to North Carolina because I wanted to get my PhD. And I wanted to get my PhD studying and working with older adults. And the reason why is, as a practitioner, I kept meeting these older adults who were just aging so beautifully. Like they were doing amazing things. And I was really intrigued as to why, like what were some of those differences.
And I have a question, like at that time, was it a thing, right? Like now we have age tech. Like when you started to get into it, what was the awareness out there about all of this?
Yeah, no, it wasn't a thing. This was before the blue zones. This was really before anything, though there was a researcher from Stanford who had written a book titled How to Live to Be 100. But it was very, very early. And one of my things as a PT and as a researcher is, why are things working really, really well? A lot of times people focus on what's not working in research, but I wanted to dive deeper into that.
So that was, you're really a little bit of a trailblazer there, because I feel as though so much of what I saw in the past was very reactionary. Like there's something that happens and then how do you treat, or it's almost clinical. And this concept of, which we care about in our role for Help for Aging in Place, as well as wisdom, is like sort of enabling or empowering people to live better. So I'm curious. So you kind of started to try to unpack the secrets of why some of these folks were sort of thriving where maybe others weren't.
Yep, exactly. And around the same time, there were some really interesting studies being published in fall prevention, like the first studies really looking at what were interventions that would really help someone prevent a fall, mostly in the exercise, strength, and balance literature. And it kind of turns out that those two things are very similar. Like the people who are doing more strength training, doing more balance training, are less likely to fall. They're also the same people who tend to really live stronger, healthier lives. And then at that point, I got really into the falls prevention literature because, and this again was really early on, this was 2005.
Wow.
There were just some really compelling, the research was so compelling. And I was really excited because I like to solve problems that are solvable. So I'm like, here's a solution, let's get it out there.
Yeah. And that brings me, because we were talking a little bit as we were preparing for this, and there's so much about falls, right? And I think there's a lot of, we were saying, some myths. Like people, there's so much out there about, and look, we've had, I think different ways of dealing with it, and so much of it, like I said, is reactive. So to have a little fun, let's dive into some of the Tiffany's myth-busting falls. All right, so you gave me a couple, so I'm going to tee up here, and you can tell me why these are a myth and maybe where they came from. So the first one is falls are a normal part of aging.
Yeah, total myth. They are not normal. It's like, yeah, and I think that myth kind of started because we do see this really big increase in the number of people who are falling in their 60s, 70s, and 80s and 90s. Fun fact for you.
Okay, like fun facts.
Yeah, this is really interesting. It's kind of mind-blowing. Typically we say rule of thumb is 1 in 3 to 1 in 4 adults over the age of 65 will fall, each year.
Right.
Well, if you're 45 to 64, it's the exact same number. It's just that in that age group, in the 45 to 64, very few are getting injured from the fall. Yes, but it truly is not a normal part of aging. We have no physiological changes that all of a sudden say, okay, fall.
Right.
We do have a lot of things that start to change that increase our risk of falling, but it is absolutely not normal and should be addressed by a healthcare provider and by the individual.
Right, which is why actually that kind of ties into some of the work we've been doing with fall detection, where a fall at 20, like you have these maybe models that are out there, then a fall at 20 is not a fall at 40 and not a fall at 60, right? And how you look at that. So I think that falls right into there. So, okay. Myth number 2. Falls occur because of the environment, clutter, bad weather, like slippery. So like,
yeah. And again, it seems kind of obvious, right? Like, oh, of course, it was really bad weather and I slipped, or there was so much clutter in my household. But the fact of the matter is that if that was true, we would all be slipping and falling, and we would all be tripping over the laundry on the floor.
Right.
And, we can definitely make environments more clean and easier to navigate. But no matter what, you should have the ability physically to navigate your environment
around there, right? So it's the cause and effect. And so,
exactly.
When you're right.
Yeah. And it is definitely something that can be part of it, but it's not the only thing. And I think that's the myth, is everybody's like, oh, we're just going to get rid of all the clutter, make the house totally spotless, and people will stop falling. And that's just not the case. It's
really it's just peeling back the onion on the cause of the falls and why there's sort of these causal environmental factors or other factors or a myth, but really every fall is preventable in terms of I think what we're going to talk about, your human movement science. So that's what we'll get into later. But okay, so the third one was this, kind of to this extent, falls, the myth is falls can't be prevented, right? And I don't know if you want to talk about that later. The last, I think, was kind of the same thing. Avoiding activities prevents falls. So you can see the theme here.
Exactly. And I do want to speak briefly about the avoiding certain activities, because we see this a lot. And we have actually had healthcare providers tell older adults, well, just sit down, just don't move because you might fall. And, it's kind of the worst thing you could say, because first of all, if you start limiting yourself. So let's say I am perfectly capable of walking up 4 steps with a handrail, but now I'm afraid I'm going to fall, so I'm not going to do that activity anymore. Well, not only now can I not go to my favorite restaurant, I'm also going to start getting weaker because I'm not using those muscles. And now, because I'm weaker, I actually am at a higher risk for a fall. So, and of course, common sense always, I'm not telling people to go be on a tightrope, but we have to, it's stop reacting and avoiding and start identifying what the problem is and acting, but don't limit yourself.
Right. Yeah, I think about that, where my mom goes up and down the stairs every day and everyone's like, oh my God, those stairs. And I think, well, that's actually strength exercise she gets going up and down in her house to take, just different, sometimes some laundry, which feels a little bit dangerous carrying the basket, but if with precaution, or if you're really concentrating, then that's good exercise, both you're holding something, you're walking. And I think I remember that in the blue zones, and I'd love your opinion on sort of those sort of thinking, but in it, I think it was Italy, they walked up the hill and down the hill, and it was sort of that movement that really was one of the indicators of sort of longevity in that case.
Yeah, well, it's, unfortunately or fortunately, it's the old adage, move it or lose it.
Right.
And the people who continue to move and to challenge themselves physically are ultimately going to be doing better because they're really able to manage some of the physiological changes that happen as we get older.
Right. So if I was like to summarize what we were just talking about, it's people assume, oh, you're going to get older, you're a higher risk of fall, you're going to fall, right? Mm-hmm. And really we need to change our paradigm thinking about this into that it's not a foregone conclusion. It's not, there's other factors and there's so many things that you can do to help that. And I think that brings us into sort of a lot of your life's work or your passion at the moment. And I know you have worked, and it'd be great if you can explain this, but you've worked on some evidence-based programs, and I know those evidence-based are public. Some of it's public knowledge, some of it's your sort of proprietary knowledge that you've put into that. But maybe just to start off, like, what does it mean when you say a program is evidence-based? I know it sounds obvious, but I think there's probably some nuances in there.
There are definitely some nuances, and I'm really glad you asked that question because as a researcher, we sometimes forget that like we have our own language, and we think this word is super important, and people are like, I have
like everyone knows what that means, right? But the average person, I bet if I asked 10 people, like one would probably know, and maybe someone, right?
Yeah, exactly. So I think people are pretty familiar with the concept of like evidence-based medicine, right, which means that, our doctors, our healthcare providers, are looking at the research and seeing what's appropriate and then applying it. But an evidence-based program, what that means is kind of amazing, where they've taken a research study and they've done a randomized controlled trial where they have the group that gets I'm going to just say an exercise intervention right now. Mm-hmm. It could be an education intervention, but
right,
or whatever. Exercise intervention, and another group doesn't get the exercise intervention. They might get something else. And they do a big study. And then at the end, what they find is that the group that got the exercise intervention, lo and behold, fell less or improved their leg strength or whatever the outcome is. And then what they did is they said, okay, well, this worked in a research setting, but what happens if we put it in the community as a program? And they do the exact same thing. They do a big study where it's not in a laboratory, it's in a senior center or wherever it's supposed to be implemented. And same thing, one group gets the program, the other group doesn't. And so basically what they're demonstrating is that this program, this evidence-based program, if it's delivered the way you're supposed to, it has a handbook, you're going to get guaranteed results. So it's really powerful.
And the key is guarantee, because that is something that really you don't hear many people say today, right? Yes. That actually, if this is performed at least to some level, you will see these benefits.
Yes, exactly. And there's probably at this point maybe 40 or 50 programs that are considered evidence-based, and they are usually recognized by either the Centers for Disease Control or the National Council on Aging. They both have been, those are two institutions that have been very influential in, hey, we need to have these programs in the community, but we need to make sure that they're going to give us the results that we need. So.
And I think of an example, maybe this is just a simple example. It's like they know if over a course of a week you reduce your calorie intake, no matter what, by let's say 400 calories a week, 500 calories a week, in 4 weeks you'll lose 1 pound or half, whatever the calculation is, that's your body's burning up this much, this takes this much, right? And I think with falls, I think really what the most interesting thing and the theme we're talking about here is that, like, if you think about it that way, if you do these proven evidence-based programs, you will guaranteed to reduce your falls. It's not, because I really do think a lot of people think falls are in some way chance. It's like bad luck, like, oh, they had a fall, oh, how unfortunate, it was an accident. Mm-hmm. It just, something came up, they didn't see it. But I think what we really try to stress here, what you're stressing is that no, it's not by chance. It's not by clutter. It's not by, just something that happened. It's really a definable state that you can control.
Yeah, 100%. And I like to talk a lot about falls almost like a chronic disease. And so, like, say you have diabetes, and you're gonna take your blood sugar assessments every day, and you're gonna take your medications. And if you don't do those things, your diabetes is gonna spiral out of control, and you could potentially die. It's a very similar model. It is, what are those things that you can be doing right now to decrease your fall risk?
Right.
And implementing those types of things.
Right. Yeah. So why don't we move on to sort of just another section that we kind of wanted to tell our listeners. So today, like if we're, I guess, different ages, but what can you do today, right, to manage your fall risk? Like, what are some of those actual things that can be taken on?
Yeah, so the super easy stuff, start small, is just actually practicing your balance. And that doesn't mean you have to go to a yoga class. That would be great. Or a Tai Chi class. That would also be great.
Right.
It just means practice standing on one foot. And find a time during the day that makes sense, after brushing your teeth or after washing the dishes. But be by a counter, put both hands on the counter and pick up a foot. And then when you're ready, let go with one hand and then both hands. But everybody should be able to stand on one foot for at least 30 seconds. And believe it or not, if you can do that, you actually lower your risk of falling. And there is data that shows if you can stand on one foot for more than 5 seconds, you actually have less of a risk of dementia as well.
Really?
Yeah.
So I was going to say, this might not be your area of expertise, and we're kind of going off topic, but is there those linkages between dementia and?
There is, and it's because, human beings and bodies are very complicated. But if you think about our balance, we have to take in all of this information from our eyes in our environment, from our inner ear, are we level,
right.
Are we off-site, and where our body is in space. We got to get all that information into our brain, and then we have to choose a reaction. So there is a huge cognitive component to our balance, and it is absolutely linked.
Interesting.
Yeah, it's really interesting.
So what other things help just to think about that are achievable in one's home without having to pay someone, without having to go to a class? What are some of the other things that we can think about at any age, really?
Yep, and again, so we got the balance piece, and then we talk about the strength piece. So strength is really interesting because as we get older, our system isn't as efficient, and we do start losing muscle mass. But we know if we do strength training, we actually maintain or even gain muscle mass. And one simple thing to do is just practice getting up from a chair without using your hands. And it's really funny because people go, oh my God, really? That's so easy. And then I'm like, okay, try it. And then they go, oh wow, I've got a little out of shape. So, and then and again, I'll have my folks, hey, let's work on this, let's do it once. And for somebody who's really on the weaker end, they can't do it once. So then I'll actually have them sit on a couple pillows and get them up high enough so they can stand up one time without using their hands.
Right.
And then, and so once you do it once, and then you do it 5 times in a row, and then you do it 10 times in a row. And then, hey, lo and behold, you're getting stronger. Now you can go up and down those stairs, no problem.
And I think that's a myth too, that you can't get stronger after a certain point, like where you actually can't build. It's just constantly going to be something that's a deteriorating strength versus building up a strength. And I know it might take longer, or muscle mass might have to be maintained, but any comments on just sort of how we build muscle, let's say after 65 versus before that? And perhaps it's different for women than men, I don't know.
Yeah, the short answer is no. The longer answer is it's a little more complicated than that.
Right.
But actually, it starts a little earlier. It starts really in our 50s. And so basically, two things happen. Our body, like I said, it's not quite as sensitive. It's not quite as reactive. It takes a bigger stimulus. And what that means is that, we can't just do easy exercise. We can't just walk. We actually have to do something to stress our muscles. We have to practice squatting. We have to practice getting up from a chair. And then the other thing is that our body doesn't respond to protein as well to build muscle. So we have to ensure that we get enough protein. Our protein requirements in our 60s, 70s, and 80s it's actually higher than in our 20s, 30s, and 40s. Yeah.
And I feel like that's also a myth, that right? In terms of your diet.
Yeah, it's really, really interesting. So, and so those two things, so if you exercise, no matter how old you are, no matter how young you are, but, if you exercise and if you lift weights or do high intensity strength training in your 60s, 70s, and 80s, you will gain muscle and you will get stronger. There was a study done on this. This is actually one of the reasons I got into aging, and this was published like in the 90s, old study, where they took nonagenarians and people in their 90s, and they had them do a weight training program for, I think it was for 12 weeks. And they had 30-year-olds, and they did the same thing, same intensities. And then they did an MRI of their quadriceps, of their thigh muscles. And what they found was that the older adults gained as much muscle mass as the younger adults. However, after 6 or 8 weeks of detraining, the older adults lost it significantly faster.
So it's really the consistency and keeping up with it, no matter what it is.
Yeah.
Okay, so really these programs, it's never too late to get started, but you do have to have resistance. Because I do hear a lot, go for your walk, which is of course wonderful, but you really need to be doing those other types of either resistance or strength or exercises, which you can all do at home.
Absolutely.
Everybody can do that. And balance is really key. Sounds like
is key.
Those balancing exercises.
Yeah, and I also, I love walking. It is a great exercise, but you also have to be strong enough to walk. And sometimes we say, hey, sometimes older adults are like, okay, I'm going to go start walking. I'm in a walking program. But their strength isn't there, their balance isn't there, and then they're at risk of falling. So it's kind of that combination.
I think one question would be, how do you know, or in these evidence-based programs, how do you know when it's okay to go to the next level? Do you know, right? Like, you're doing this, and you want to, stress yourself, and if you don't have a Tiffany there, or you want a program, you're like, okay, I've achieved this, I've done this, now I should move on to do that. Do the evidence-based programs also give you a little bit of a map to follow as you go forward?
Yeah, some of them do, and this is it's a big challenge, and it's a big challenge to start because so many, as we get older, we do have, we're typically, our health history is not straightforward.
Right.
So my mom is a great example. She's had spinal surgery, she's got osteoporosis, and how does she start an exercise program?
Right.
And starting slow and having some guidance, super, super helpful. And then when you get to your point, which is where we want to be, let's go to the next level. So certain programs actually, in the program I'm the most familiar with is called the Otago Exercise Program. It was developed at the University of Otago in New Zealand. That's why it has that name. But it actually has a progression. So once you're able to do 3 sets of 10 of an exercise, you either are going to increase the weight or you're going to increase the challenge. So there's a really nice progression that way. And then the other thing I tell people is hey, when this is super easy, it's time to, go check out something else. Because now maybe you don't need a full evidence-based program. Now maybe you can go, go to your senior center or use your silver sneakers or use whatever you want to use, because now you've actually really improved your balance and strength.
Right.
And so there's a little bit more flexibility in what your options are.
Yeah, it really feels like building blocks. You hit this and then you kind of get to that next level, and then it all builds on itself going forward, but you kind of have to start somewhere. Yes. But even starting somewhere has the I always think the line of diminishing returns, but the advantages of getting started is so great in terms of the benefits. Good. All right. Let me talk a little more about fall prevention and kind of state of the where we are with sort of the age tech industry and what everyone talks about. And what I really want to ask you, so for you, what's important for you right now in what you're doing, right? Where do you want to take your work and all of your research and career? What's important for Tiffany going forward?
Yeah, so I've really come to the conclusion it is all about empowering the older adult to have the tools that they want and need to live the life that they want and that they need. And it's been really interesting going through this journey as both a clinician and a researcher. And just seeing that we're not getting to where we need to go. In fact, if you look at the death data due to falls, not to be a total bummer here, but it's actually way higher in 2024 than it was in 2023 than it was in 2020. We're going the wrong direction. And
do you have thoughts on why? I mean, I'm sure COVID didn't help that.
Yeah, COVID definitely did not help, for sure, because people are isolated,
Right.
and there was loneliness, there was so much happening. But I think the other thing that we've done, and there's always unintended consequences when you do research, but we really got on healthcare providers about, you have to start screening your patients for falls. You have to. But we didn't actually provide good guidance as to, okay, they screen positive, now what do you do? And so what we've seen a lot of is, and people who are listening may have experienced this, your doctor asks, or their aide asks, hey, have you had a fall in the last 3 months? And you say yes. And they go, oh, and nothing happens. And I think that is a very strong message to the patient that, well, this isn't important because we're not going to do anything about it, or there's nothing we can do about this because we're not doing anything about it.
Right. It goes back to our first 10 minutes of conversation. And I think this is the message really that needs to get out, is that it's still a reactionary, like, oh, you had a fall. Okay, then what was the consequences of that fall? Right? Or what are we going to do now to X? Or you need to declutter. Or it's like all these reactions to falls, and there's just not enough societal support for this fall to get ahead of it. And you can. And people, like, if you put sunscreen on and go to the beach, you won't get sunburned, right? Like, this is like, right? There's actually something you can do. And the message really isn't, and if people knew that it worked, right? That if you just did these things, there's evidence to say that you would prevent it. Like, in terms of that doctor's office and the health information, like, what should people be asking their doctors? Like, what is the most important piece of health information that you want as you get older? Like, how can, we sort of help educate people on what to ask their doctors?
Yeah, that is a really, really great question. So, there's two things. I mean, one, when you're in that doctor's office and those questions are being asked, the first thing that I would say you should do is, are any of my medications contributing to this?
That is such an important point.
Yeah, because we know, and one of the number one risk factors for falls, besides balance, besides difficulty walking, is what we call polypharmacy, which is either too many or the wrong kind of medications. And there are, so that would be my number one thing, right?
And I find that, and having gone through this with my dad, where I'm like, oh my gosh, who gave you this prescription? And did this doctor talk to that doctor about that prescription? And did anyone check if these interact with one another, and then another one? And I feel like there's just no, I feel like this is actually something that AI could really help with, in terms of like loading all, like what are the potential cause and effects of these, where it could be diagnosed easily, because I think right now it's a time-consuming process to stitch all these together, and that's for another conversation about technology. But the medicines are a huge thing. They are a huge thing, and honestly, the data shows that once you're on more than 8, you're at a 100% risk of having an adverse drug event. And what that basically means is one of your meds is resulting, you're having some sort of a physical response that will be negative due to all of these medications. Right. Okay. So that's a piece. That's one great question. What else is there to ask the doctors? Yep. And the second thing is, hey, I know I'm at risk of falling. What can we do together? Do you think I should go see a physical therapist or an occupational therapist? Is this a vision thing? Is it a proprioceptive thing? Is it a inner ear thing? Just asking questions like, if I fell, can we take some time to figure out why? Right. And, what are the risk factors, the medical risk factors that your physician can help with? I mean, they could assess if you have something called orthostatic hypotension, and what that means is when you stand up, your blood pressure drops too much, right? And you get dizzy and you can fall. Yeah. So, hey, what help me out here? What can I be doing right now? Right. And it's like you get all these screenings, you get your blood tests, you get your mammogram, and all of your other screening, colonoscopy, like you're doing all of these things. And you're right, there's just not this concept of, great, you went this year without a fall. Like, that was great. Like, you're marking that down as like a real benefit of your health and just having that program. So it does feel as though there's so much more that could be done in this area, which instead of just being so reactionary.
Yeah.
I'm curious, I have a couple more questions to wrap up. One is like, if we all wanted to learn more, just there's so much information out there, but there's a lot of information that might not be like accurate, or where people are suspect, right? Of like, where are you getting your information from? Where would you go, right? What are the best places to go? I mean, I know we're putting things on Help for Aging in place. There's other really great American on Aging, there's AARP, there's lots of great resources, but where would you try to simplify this?
Yeah, so I send everyone to the Falls Free Checkup, which is on the National Council on Aging's website.
And we'll put that, you send that and we'll put that in the chat when we publish this.
Yeah. And the reason why I do that is it's 12 questions that you answer. And when you're done, you actually get a PDF with your results and what you marked as at risk, why that's a problem, and then also it actually will generate a letter that you can take to your healthcare provider. And it's free, and it's evidence-based. Like the tool has been tested multiple times, and so I just find it's a really great education tool and an empowerment tool.
And what do you think the right age is to start this? Like realistically, I know it's like, your mammograms start at right. Yeah. So I know there's probably no great answer for that, but
it's so we talk a lot about chronologic age versus physiologic age,
right.
And I would say you start taking this when you start feeling like you're worried you're going to fall.
Right.
Just because it's going to give you that great information, and then you could always as well, like when you're 65, you're supposed to get a fall screening at your annual Medicare wellness visit. That's the other thing you can do, is just like, okay, I'm 65, I'm going to start taking this Falls Free Checkup and just starting to assess and manage and track my own fall risk.
But to your point on those screenings, is there enough proactive, actionable call to actions after that screening? Is there enough that's happening after that screening?
Right. Again, it's all on the individual.
Right.
Yeah.
All right. So two final fun questions for you. Sure. I mean, obviously, like in terms of one thing that you would want your name on, like Tiffany, like in terms of an impact to the world. So in 20 years, this is when I ask you this, like in 20 years, because if I look back, and I'll give you an example of what I'm trying to think about, like seatbelts. Like I was a child of the 70s. We had a paneled Caprice Classic station wagon that we drove around in, and there was like, I was not wearing a seatbelt. I was like bouncing on the back seats, like in the front, in the back, like hopping over, just not wearing a seatbelt. And now, of course, you can't get into a car. So somewhere along those 25 years, right, like that all changed. So if you were to imagine what it's going to look like in 2045, right, and what you would be like so proud to say, like either something you impacted or what the end state goal would look like for this generation and falls, is there a big picture that you'd like to see that's like fundamentally a shift, kind of like that you weren't wearing seatbelts and now you're wearing seatbelts?
Yeah, no, for me, it would be people being able to assess their own falls risk and really engage with strength and balance exercises. So if I as a PT walked into somebody's home and I was gonna start my assessment of them, instead of them showing me their blood pressure readouts, which literally just happened the other day, like here's my blood pressure for the past 10 days.
Right.
I would love my patient to go, here are my fall risk scores for the last 10 days.
Right.
Here's what I'm doing. Here's where I need a little help.
Yeah.
I mean, if we got to that point, I think we would just be in a completely different situation.
Where fall risk is another health metric, right?
Yes.
Because I have, I do wear my Garmin watch. I was like wanting to really understand my sleep, like what was happening, like if I wake up in the middle of the night, but I don't see a fall risk score here. I've got every other kind of health score. So where you're saying is really take falls to the next level, the awareness of it. You can do something about it now, it's not something that happens to you.
Yeah.
It's just like you said, diabetes. It's something that you can control, that you have control over. And that's really what we want to get the message out. Like, don't, not to say there's like be the victim, but there's so many proactive things you can do to empower yourself and live that, happier, healthier life.
Yeah, and the impacts are fantastic, because it's not even just you're going to have a lower risk of falling, but you're going to be stronger, you're going to be more mobile, all of the things, it's all kind of wrapped up in being able to understand what these risk factors are and do something about it.
Yeah. And how about you? What do you do for yourself, right? If it's like being...
Yeah, no, I do strength training twice a week, and I run, but I also stand on one foot a whole bunch.
Right.
And it's really funny because I have I've had multiple ankle sprains, and I just, like, if I don't practice, it's really funny. Like I need to practice.
And it's so easy. I'm like, okay, I'm cutting carrots. Like, let me stand on one foot, right? And do that and make it fun. So
I do while I'm brushing my teeth, and then it's really entertaining because you're like, what?
But it's just something you can do all the time.
Yeah.
Well, great. Anything else you want to share? Like anything else on your mind that you want to share with our listeners, the audience?
Yeah, this has been a wonderful interview.
So
Thank you so much. I think the main thing is that people just, don't give up hope. There's so many great opportunities out there for you to engage with, and really make a big difference in how you lead your life.
Well, we really appreciate all the work that you've been doing, and obviously I look forward to continuing this conversation and having you back on and just kind of keeping you as a regular contributor, because it's so important. It's just so fun. It can't be more front and center for people. So anyway, well, thank you. We will point folks to sort of some of the links that you mentioned and any other kind of like great places. And let's kind of keep this. It's not a one and done conversation. This is something that's a journey. But I'm with you. Like, I want to get it to that point where, the seatbelts and sunscreen of the falls, right? It can change. It can. It's just a matter of people being educated about it and having these tools available to them. So, all right. Well, have a wonderful rest of the day and week, Tiffany, and we will talk to you soon. And thank you for joining Sage Space.
Awesome. Thank you.